Welcome to the Lyme and Other Tick-borne Disease webinar. I'm Peter Baumann, President of Southern Tier Lyme Support. I'm sitting in for Mackay Rippey, who is ill and therefore cannot be with us tonight. We wish Mackay a speedy recovery. We are very excited about this conference. Our speakers are frankly outstanding. We are delighted to have Dr. Michel Shamoon from Binghamton University, Ross Douthat from the New York Times, as well as Dr. Brian Fallon and Dr. Shannon Delaney from Columbia University. Our webinar is brought to you by Binghamton University's Lyme and Other Tick-borne Disease Research Center and Southern Tier Lyme Support. We at Southern Tier Lyme Support are grateful to the Tick-borne Disease Center for the key issues they are addressing. These include diagnostics and treatment, ecology, epidemiology and risk modeling, and public health education and outreach, all focused on Lyme disease. There are currently 25 researchers associated with the Lyme Center. Recently, the Lyme Research Center has developed a biobank to share more than 15,000 biospecimens with other researchers. The items in the bank include ticks, rodents, their pathogens, and their DNA, as well as dog and human specimens. As we go into the conference, please note that there is an Ask Questions button at the bottom of your screen. If you have questions, please type them in, and if time is permitting, we will try and ask your question. I would now like to introduce Dr. Michel Shamoon, who is an assistant professor at Binghamton University and an associate, I'm not sure where that sound's coming from, and an associate of the Tick-borne Disease Research Center. Dr. Shamoon is a molecular anthropologist and is involved in the university's first-year research immersion program. Dr. Shamoon's research focuses on the diagnostics of Lyme disease and on the genetics of deer ticks in the greater Binghamton area. He knows a lot about Lyme disease and ticks. Dr. Shamoon, thank you very much for being here today.
Absolutely. Thank you very much, Peter. And I would like to thank the Southern Tier Lyme for this opportunity. I think for the sake of time, if you don't mind, because I have quite a few slides to click through, I'm going to go ahead and start sharing screen starting with the title of the site. All right. So quite frankly, it might be a few too many slides for a 20-minute talk or so. So I might go, but I figured I'll just have more of these slides and maybe get back to them if we had some specific questions. But before I actually get to some of the slides with more information, I figured it's important to begin by emphasizing the fact that this talk is an attempt to provide a brief description of the current situation in Southern Tier region. Specifically in terms of the types of ticks and tick-borne diseases that may lead to human diseases, and what is our understanding of the current risk involved. I also thought it's a good idea to actually start with the conclusion or the take-home message, which, while the reality is somewhat alarming in terms of the rapid growth of tick and tick-borne diseases in most of the Northeast. In fact, I think we should just focus on the only proper response, reaction, which is taking action, on the level of governments, both federal, state, local governments, the NGSs and communities, but also individuals. And by that, like I said, starting with the take-home message, I really believe that we should focus on prevention, not that we should abandon treatment. But for three reasons here, I really think that prevention is more important. First and foremost, because as you will see, we are basically dealing with about half a dozen different pathogens, and not all of them require the same or even similar treatments. So you can see how having an approach to treatment and diagnosis, considering the complications and issues involved with both of them, with several tick-borne diseases, really makes it a better approach if we just could prevent such infections in the first place. Also, virtually none of these tick-borne diseases can be transmitted from a person to person. So no ticks or no tick bites, therefore no tick-borne diseases. Also, as probably many of you have heard, we are dealing with an increasing number of other diseases that are non-pathogenic, which are simply caused by a tick bite. And I'll get to that in a few minutes. And finally, basically, when I talk about focusing on prevention, I think we should be focusing on preventing exposure to ticks. But when we are exposed, making attempts into, or at least being informed in the first place about how to check for ticks and properly remove them if you find a tick on yourself. And this is on a different level, but we really also, I believe that the best approach, specifically in prevention, would be with focusing on the development of anti-tick vaccines. So their Southern Tier Lyme, along with Binghamton Tick-borne Disease Center, can provide quite a lot of information about how to do so, but also encourage you to check out the CDC Lyme prevention pages, as well as the health departments of our counties in New York State, upstate medical, particularly the Tangamani lab and Cornell's What's Bugging You pages. Also, I encourage you to check them out. They can be very useful. Now, to begin with some more specifics, I'm sure we all know that the situation in Northeast when it comes to tick-borne diseases has been only worsening quite steadily in the past couple of decades. An example of better established data from 2019 from New York State is over 4,000 confirmed cases or probable cases of Lyme disease. I'll get to how this is actually an under report, probably by a factor of 10. But also in general, we also have increasing number of spotted fevers, and although some like Powassan virus infections are rare, but they could be life-threatening, and they also are an increase. So I'm not going to go through the names of all these ticks here, because in the following few slides, I'll talk about each of these 7 types of ticks, which to the best of my knowledge, that should be about all of the ticks that we can both find in our region and that also can potentially transmit to us human pathogens, beginning with the most important one, the black-legged tick or deer tick, Ixodes scapularis. As you probably all know, it's a vector for Lyme disease bacteria, but also for anaplasmosis, babesiosis, ehrlichiosis, and the Powassan virus. Another issue, particularly with ticks like deer tick, is the potential for polymicrobial infections. Simply, all of these 5 pathogens could be carried by a single tick. In fact, in multiple studies, they have found one or multiple ticks that were infected with 4 or 5 pathogens. If that's not clear what it means that someone like myself, getting bitten by a single tick can simultaneously acquire 4 or 5 pathogens. Lone Star tick, which has been an increase in our region, is a more aggressive tick in the sense that it is more mobile and it's faster. It also carries at least 3 pathogens particularly these 3 pathogens in our region, for ehrlichiosis, for spotted fever, rickettsiosis, and tularemia, although both of them are quite rare in New York State and in Southern Tier. But it's a good example of those non-pathogenic situations that I briefly mentioned earlier. There are 2 that we are aware of that can be caused by a Lone Star tick bite. The Southern tick-associated rare illness, or STARI, which causes a Lyme-type rash and can, in many cases, lead to fatigue, fever, headache, muscle and joint pain for weeks after that. And somewhat more importantly, because rarely it could also be fatal, is the tick bite-induced allergy, or alpha-gal syndrome, AGS. You might have heard of this. Someone who is not allergic to meat, well, red meat is not correct, meats or milk from any mammals, basically overnight after a tick bite, they might start having very severe allergic reaction to meat or milk. And so far, as to the best of our knowledge, this is simply caused by the tick bite itself, and regardless of the presence of a pathogen. The dog tick, or American dog tick, some of us might know it as wood ticks, they also carry Rocky Mountain spotted fever and tularemia. As I said, they are quite rare, but a possibility, and both could be. I'll briefly talk about basically the situation of those diseases. There is also a non-infectious disease caused by a wood tick bite that we simply call a tick paralysis. It isn't actually now is quite well established that there is a neurotoxin, a toxin that has an impact on our nervous system in tick saliva that leads to tick paralysis. There is increasing evidence that the black-head leg or deer ticks, as well as Lone Star ticks, both of them quite common in our region, also may cause tick paralysis in rare cases. That is still something that is not well established. With brown dog tick, again, for people who have pets, particularly dogs, might be familiar with both of these types of dog ticks. They are quite prevalent. This one is even less likely, but still a potential to carry human pathogens, mainly Rickettsia rickettsii as an agent of Rocky Mountain spotted fever. Like I said, both of them can cause human pathogens, but they primarily carry a range of dog or canine pathogens. Finally, there's groundhog or woodchuck tick, Gulf Coast tick, as well as the Asian longhorn ticks, which is in basically the last two are rather new, have been introduced to our region only the past few years. I was actually quite surprised with Gulf Coast tick because, to the best of my knowledge, it was first reported in New York City area about 2020. But looking at the records, I realized that two Gulf Coast ticks were identified in Broome and Tompkins County just last year, and both of them are actually infected by Rickettsia parkeri. So they are here, and the risk exists in our region. With Asian longhorn ticks, primary concern, as you might have heard, is a cattle pathogen, which is a blood parasite, but they also may cause Rocky Mountain spotted fever and tick paralysis in humans. They were not reported in the US before 2016 or 17, but now being reported from places close to our region, and they most likely actually are already present in our region as well. I'm not going to spend much time on Lyme disease. Others will talk more about it. I'm also assuming that most of us are more familiar with the Lyme disease compared with the others. But just a few words. Borrelia burgdorferi is a bacteria, a spirochete, that causes Lyme disease. The prevalence has been increasing in deer ticks, and it quite directly translates an increase of cases in humans, which, while quite high, there is very good reason to believe they're underreported, probably 8 to 10 times more cases than those that are reported. When I was checking, this newer CDC estimate puts the number of yearly cases at around 475,000. So somewhere about 50,000 of them probably are in New York State. Like I said, not going into the details of it, but Lyme disease usually starts with an early localized infection, may or may not be a bullseye rash present, but then it disseminates and eventually may disappear, but in many cases may lead to late Lyme. And as you probably know, there are individuals who, even after the treatment, have struggled with issues that we sometimes refer to as the post-Lyme disease syndrome. Carditis and meningitis are among some of the higher risk complications involved with Lyme disease, but also want to bring your attention to the fact that we are having increasing evidence of we always knew that co-infections were possible, but now we are discussing between a quarter to a third of the cases. The patient is also infected with anaplasma or babesia, and sometimes both of them, which can lead to complications when it comes to the treatment, and so on. So babesiosis, which is caused by Babesia microti, a red blood cell, a parasite. According to New York State, is the second most common TB pathogen. I think in our area, it's also you will see later that why I said it's the second or third, but I think it's in our region, in southern tier, numbers that I'm looking at, sometimes it's between 3 and 5, but in other cases, 9 to 25% of nymph and adult, ticks are infected with babesiosis agent. And like I said, in this case, more specifically, 25 to 29% of Lyme patients also might be infected with B. microti. It could be asymptomatic. In many cases, it's very mild or causes a flu-like kind of a condition that might last for a few weeks. Along with joint pain, and it is a red blood cell parasite, so it can cause anemia. And so far, we are particularly concerned about people whose spleens have been removed, or elderly patients and immunocompromised patients, because they are the ones who more often suffer from liver or kidney failure and other life-threatening forms of babesiosis. Anaplasmosis and ehrlichiosis are quite similar, and they're both caused by closely related intracellular bacterial infections. Both of them have a wide range of symptoms. About 4 to 5 days, sometimes up to 2 weeks after the bite, symptoms start. You will see a pattern of similarity of all of these blood pathogens. Usually you have some sort of a fever, a chill, followed by muscle ache, headache, etc., weakness and fatigue. It could be life-threatening, but if untreated, especially in immunocompromised and elderly, although the mortality rate is usually considered to be on the lower side. To be more specific, I'm just going to show you this picture on the left side, the agent of ehrlichiosis in humans, E. shafiensis, compared with Anaplasma phagocytophilum, both of them, as here being identified inside white blood cells, inside monocytes and neutrophil, which is an important way to basically identify and distinguish these two pathogens. A little bit more on anaplasmosis, which again is the second or third most common tick-borne disease in our region and many parts of Northeast. One thing to know is that it's kind of important when it comes to the data that we are reviewing, and also sometimes it might be important in terms of diagnostics, is the fact that there are in fact two types. The type referred to as APV1 actually is not known to cause to be pathogenic for humans, but the other type is. And I mentioned earlier that deer or black-legged tick carries anaplasma, and if untreated, like I said, so it can lead to leukopenia. So basically, a significant drop in number of white blood cells, also platelets, which can cause several issues, respiratory failure, organ failures, and fatality rates is relatively low compared with ehrlichiosis, which we know has a higher mortality rates. I will just emphasize a couple of differences here with ehrlichiosis. You also have central nervous system or CNS involvements, and which is why also basically confusion is one of the symptoms that is more common with ehrlichiosis. There is also a rash involved, although only in 30 to 40% of patients, usually younger patients. Another difference with ehrlichiosis compared with anaplasma is that infants also seem to be high risk in case of ehrlichiosis. Another thing here is while fatality rate of, let's say, about 3% is relatively low, we are looking at a great chance of hospitalization in all severe cases. In fact, closer to 60% of individuals with, with severe symptoms will require hospitalization. So that is something that is quite significant. I'm going to move over this, but as a reminder, and again, those of us who have dogs and are familiar with dog infections might have heard of ehrlichiosis as a canine disease, but some of those agents can also cause disease in us humans. Another one that, another pathogen that might be basically, it is less common, and I'm assuming that our audience might know less about, is Powassan virus. It's been quite a while since it has been identified, and it remains rare, but I think it's considerable to think that it has become, the annual number of cases of this virus in the past few years has quadrupled compared with the mid-2000s. So at this rate, we might be looking at several hundred cases per year in a couple of years and thousands, by the end of this decade. A few thousand cases might not sound like a lot unless you realize that at least so far, based on the 181 confirmed cases that have been studied between 2010 and 19, we are looking at over 12% fatality rate, which is very high. Also, an unfortunate situation with Powassan virus is that in 2 studies at least, and they could confirm that a tick bite that lasted for less than 15 minutes, meaning the tick was properly removed in around 15 minutes after the bite, a tick successfully infected that individual with this virus. So almost instantaneous infection compared with some of the other diseases that might take several hours before they are transmitted. Because like I said, my goal here has been to provide a briefing of all those pathogens, tick-borne diseases in the region. I'm also going to briefly mention spotted fever rickettsiosis, or SFR, which includes the Rocky Mountain spotted fevers, RMSF, are caused by a number of closely related rickettsia bacteria. Again, we only have a few dozen cases per year, but they could be fatal if untreated, and also because they are rare, sometimes they remain, undiagnosed or misdiagnosed. Although treatment is actually highly effective and relatively straightforward. With Borrelia, we also have Borrelia miyamotoi, which causes some sort of a relapsing fever, which could take a few weeks to develop, and it might last for over a month. Tularemia is another disease that I mentioned earlier that is quite rare. I did not find any cases reported in our region as resulted from tick bites, although dog ticks can transfer it to us. And finally, cat scratch disease, which I have to say that this is the one that is least understood in terms of if it really can be transmitted to us with a tick bite, but there is quite some evidence that it's a possibility, although it is rare. Now, before I present to you some data of the situation more specifically in our region, and Peter kindly mentioned the Tick-borne Disease Center, Binghamton University's Tick-borne Disease Center. In the past, we would report from our work, because under the guidance of Dr. Ralph M. Garudo here in Anthropology Department at Binghamton University, the group has collected thousands of ticks over the past decade. That said, we have not collected many ticks during pandemic the past couple of years. So that's why I will be actually drawing on some other sources to brief you on the current situation in Southern Tier. But a few words about our current research is basically what mostly my students and I, but also working with Dr. Garudo, and in the case of our new publication in collaboration with Dr. Rietcher and his group in Pharmacology University here, from Pharma School here in Binghamton. So we are making an attempt to better understand the nature of Borrelia burgdorferi strains in our region, but also novel diagnostic tools. Again, Dr. Hathout's group primarily focuses on basically proteomics, use of proteins for screening, and in our case, our approach is mostly genetics. And a new member of our department and Binghamton University, Dr. Matthew Emery, has been also working with us on taking a next generation sequencing approach to better understand not only the pathogens carried by ticks, but overall the tick microbiomes, meaning all the microbes present in any given tick, which seem to play a role in the risk of pathogen transmission to humans. Now, as I said, so I'm gonna draw on two separate sources of information to brief you on current situation. First, the Tangamani, Dr. Tangamani's lab up in upstate. So they have an excellent, basically, website which you can check for some details. Here, I figured I'll start first by giving you a brief on the situation, more specifically in the past 3 years in Broome County. You are looking at the middle in greens and the number of different kind of ticks, starting with I. scapularis or deer tick, and on the right side, pathogens observed, the percentage of their frequency among ticks. Overall, in the past 3 or 4 years, over 30% of those ticks in Broome County, in this case, were positive for Lyme, and quite a large number of them also for babesiosis and anaplasma. Ehrlichiosis and Borrelia miyamotoi also has been was diagnosed, was identified. But particularly the last year, actually, this is the data for ticks collected or reported since April 15th, 2021 till today, so almost the past year. As you can see, the numbers don't change much, but they're quite high, so we are getting closer to 40% overall in terms of the tick infectivity. Over 17% for babesiosis, 7% for anaplasmosis, and a small percentage of some other pathogens. Perhaps of a greater interest to everyone in the whole 8 counties that I included, this one here, again, just only in the past year, over 1,600 ticks that were tested. I would like to bring your attention on the right side on what seems to be the average, the overall percentages of infections. Again, we're looking at about 35% for Lyme and about 10% for babesiosis and anaplasmosis, small percentages for 3 other pathogens. Now, the next few slides are some tables that I made, using the basically raw data from the New York State health data. Here, we'll start with the adult deer ticks. I know this might be quite a lot to look at, so I suggest that you just focus on maybe the top 2 rows when it says Southern Tier. I'm presenting to you here the averages for 2018 to 2021, and you can compare it also with the preceding 10 to 11 years of 2008 to 18. The color codes there, basically the darker shades of red represent higher frequencies, green for 0, and shades of yellow and orange for everything in between. We do have some, also really alarming, values here, as you can see in certain counties at certain years, close to 70%. For Borrelia burgdorferi, the causing agent of Lyme. and anywhere between 0 and but 36% again in case of Tompkins in 2020. I think these are really interesting numbers, and they not only show an increase, a constant increase in the prevalence of these pathogens, but also again thinking about the risk of co-infection, especially with deer tick. We should understand that these numbers kind of add up to that risk. Here I'm presenting, this is a different presentation by county, but different years. Again, we might not see a very clear pattern from this data of whether these infections are increasing, but we must also realize that there are differences in the number of ticks that were collected or tested every year. So what I would say is more important than just looking at maybe some averages or sums of the data from the past couple of years, which again suggests somewhere close to half of the ticks in southern tier are infected with Lyme disease bacteria, and somewhere between 1 and 7% of them with the other 3 pathogens that have been tested by New York State. And there are some differences overall in places like Tompkins County and some other counties. We have slightly higher percents of certain pathogens. So I think my time is about but very quickly, if you want to also compare, because we also have this nymph deer tick data provided by New York State. Here I'm presenting to you the averages basically for the 2018 to 2021 as the latest the data that we have. It is quite concerning to see that virtually all of those pathogens are present in usually significant frequencies, both in adults and in nymph ticks. Go ahead.
You're muted.
Yes.
Am I muted? Can you hear me?
Yes.
Okay. Thank you so much for your excellent talk. It is so reassuring to know that you and other researchers like you in our community are doing this kind of research. We, as in the Lyme community, the Lyme patient community, are very grateful to you. I have just a couple of quick questions for you. One is,
absolutely.
You read that it takes 24 to 36 hours for a tick to pass its venom onto a human being once it's embedded. Is this true?
So I'm not sure if you. So I think we should be talking about in terms of pathogens, right?
Sorry, I used the.
No. So that's my point is just because it depends on the pathogen. And we also have to be a little bit cautious because for quite some time we were comfortable with reassuring people that Lyme disease bacteria is impossible to be transmitted under 36 or under 24 hours, but there have been cases that suggest that this can happen quite faster than that. So I would still say that it's, and as I have this, and this is my last slide up here, and we still should really be prepared to find ticks and remove them as quickly as possible. But in case of viruses, for instance, sometimes transmission could be almost instantaneous, or at least within 15 seconds. There are some other pathogens that we think a tick can transmit to us in a couple of hours. With Lyme bacteria, hopefully there's a longer time period, but we are not sure that 24 to 36 hours is correct anymore. It is possible to get Lyme disease from a tick even in a shorter time period.
Thank you. And I guess one of the ones you mentioned earlier that can pass through to the human body quickly is the Powassan virus. I note that in last March, the Pennsylvania Department of Environmental Protection indicated that on the Iroquois Trail in Tunkhannock, Pennsylvania, 80% of the ticks were found to have Powassan virus. Is that something we should be concerned about? Tunkhannock is 50 miles south of Binghamton.
Right. And thanks for, bringing this up, because I remember, we talked about this, I think it was last month, right? And that you brought this up. Um, as you could see with the other values, here's the thing. Let me just put this simple. The reason that, let's say, we cannot really necessarily combine all of these data together and present them in one place is that because, some centers or some groups test for a certain type of pathogen while the others focus on something else. In terms of viruses, depending on if it's a DNA virus or an RNA virus, just to put it simply, the methods of diagnostics could be different. So all I'm saying is that we do not have many places in our region that has been testing for Powassan virus, but it's something that we actually, I personally in my lab, so we are planning to actually, test some of the ticks that have been collected here, and I can promise that as soon as we have a good number of ticks tested to report. We just need to understand that some of these tests are not 100% specific or sensitive. So, and I think that is one of the reasons that we have some discrepancy, across different sources and how high. Going back to that 80%, again, I cannot comment on the specifics of that report, but let's hope that it's less than that. The issue is that this infection is not as well known as, let's say, Lyme disease, obviously. So it is easier to be underdiagnosed, and also it has a very high fatality rate compared with many other tick-borne diseases. So those three layers of complications together, I'm afraid, makes Powassan virus potentially an important pathogen as well.
Well, thank you very much, Dr. Shamoon. We so appreciate your talk and your time here tonight. Thank you.
No, absolutely. Thank you for the opportunity.
Thank you. Here. We are now going to be taking about a 1-minute break or so, and our next speaker will be Douthat, and we'll bring him up in just about a minute. Our next speaker is New York Times opinion columnist Ross. And how do you pronounce your last name?
It's Douthat, imagine like the Dow Jones.
Okay, thank you. Douthat. Mr. Douthat has experienced chronic Lyme disease symptoms for the past 7 years. His book, which is right here, by the way. There it is.
There it is.
Okay. His book, The Deep Places, a memoir of illness and discovery, describes the journey he has undertaken to battle the illness. The book is a powerful, clearly written memoir that captures the essence of what it can be like in the struggle to feel better. It is an amazing book, and we're very pleased to have you here today to speak to our group. Thank you.
Thank you. Thanks for the kind words. So I'm going to try and talk for a few minutes on some of the themes of the book, basically sort of telling a kind of capsule length version of my slightly epic, although by Lyme standards, not even really all that epic, Lyme journey. And then talk similarly quickly about some of the things that helped me to get better. And hopefully it will complement the last presentation with its focus on diagnosis and prevention. This is not a story about prevention, and it is a story about diagnosis, I suppose, eventually, but mostly it's a story, again, I think a fairly characteristic story of what it can be like to get Lyme disease and what you can try and do about it. So for me, the story starts in 2015. My wife and I, at that point, were both living in Washington, D.C., and we were both from New England originally, both from Connecticut, in fact. My mother's family was from Maine, so we had deep roots up here, and we always had this idea that we were going to move back at some point to the Northeast. And part of that idea of moving back was this kind of fantasy of I guess you could say, the rural life. We lived in a small row house in Capitol Hill. We had 2 little kids, and we, and maybe especially I, had this idea that we were going to own a big place in the country, ideally something colonial, something built 200 years ago, something with land and stone walls and all those kinds of things. And in 2015, we put our small DC row house on the market. The DC housing market, then as now, was really, really hot. It sold for more money than we had expected. And rather than doing something sensible like investing in Tesla or Bitcoin, we took all that money and plowed it into our dream house, this 1790s farmhouse that did indeed have stone walls and fields and a pool and a guest house. Basically everything you could sort of imagine for the kind of rural New England dream house. And it was about an hour, a little over an hour from New York City. It was in the town where my wife had grown up. And just after we did the inspection on the house, which of course turned up all kinds of crazy things that we foolishly assumed would be easy enough to fix, we were back in Washington, D.C., and I woke up with a little red swelling on my neck, right around the lymph node. And I went to a doctor in DC, and they told me that it was a boil, some kind of small infection, that there was nothing really to worry about, and that it would go away. And it did, in fact, go away. But then over the next few weeks, I started getting strange pains in my neck, pain radiating up into my skull, down around my teeth and my gums. And then at a certain point, I kind of had this sort of meltdown where I suddenly sort of had bizarre pain and discomfort and feelings of vibration and tingling all over my body. My bowels liquefied. I couldn't sleep. I went to the emergency room. I got a bunch of blood tests. They were all negative. I went home. And then this set in motion this period of about 2 months in DC, where we were still living. You know, we had bought the house in June, but we were planning to move in August. And over those 2 months, basically my condition just steadily deteriorated. I had, terrible pain across my chest that seemed like a heart attack. I would make emergency room visits where, again, nobody could find anything wrong. I lost about 40 or 50 pounds because my stomach was a mess. I couldn't eat anything. I couldn't sleep at night. If I would fall asleep and be awakened with a feeling almost like an alarm clock going off inside your chest, sort of pulling you awake. And so I saw doctors. We were, sort of, normal Washington, D.C. professionals. So we sort of went through the run of different specialists. I saw, when I had chest pain, I saw a cardiologist. For my stomach, I saw a gastroenterologist. But I saw a whole array of doctors. I probably saw 10 doctors in those 2 months. And none of them could figure out what was wrong with me. And generally, at a certain point, the idea was, well, we were moving. We were actually having our 3rd child. My wife found out she was pregnant just literally the day that I discovered the swelling on my neck. And so the doctors would sort of be understanding and sympathetic and say, look, you're under a lot of stress. You're having some sort of mind-body interface, by which they basically meant that I was having a nervous breakdown. And of course, I was, completely willing to believe this. I was willing to believe anything that promised some idea of treatment. So I dutifully took sleeping pills and antidepressants and anti-anxiety medications, Xanax, and so forth. I went to see a psychiatrist, and none of it made any difference. And then somehow we dragged ourselves up to Connecticut, to our dream house that now seemed like a bit of a nightmare. And I started seeing doctors in Connecticut, and there was a pretty big shift pretty quickly, where the first sort of general practitioner I saw and the psychiatrist that I went to see both said, well, we see a lot of pretty weird cases up here in New England. You should, you you have tested negative for Lyme disease, but we should consider tick-borne illness as a possibility. And the general practitioner had me do a trial of antibiotics. And I had this immediate response to the antibiotics where basically they stabilized me. I went from sleeping an hour a night to 4 or 5 hours. The phantom heart attacks went away. This sort of feeling of disassociation, like my body was basically dissolving, went away. So that seemed like an indicator that I was on the right track. But then from there, I didn't make any progress. I took 1 course of antibiotics, I took 2 courses of antibiotics, and I didn't get worse, but I also didn't get better. And what that meant was that I still had pain all over my body, migratory pain, joint pain, muscle pain, you know, and again, these sort of weird tinglings and neuropathies all over. And so at that point, I basically went from the mystery phase of the illness, where I had no real idea what was wrong with me, to the medical controversy phase of the illness, where I became one of these patients that, you know, most of you will be very familiar with this drama, who probably has Lyme disease, doesn't get better with the CDC recommended 4 to 6 weeks of antibiotics, and has to decide what to do. And you know, this eventually led me into the world of what gets called Lyme literate medicine, where I saw doctors who will treat you for Lyme symptoms, even if you don't, you know, have an exactly positive test. My Lyme tests, I eventually realized, were showing up as 3 or 4 bands on the Western blot test out of the 5 that you would need to get, again, the official CDC diagnosis. At a certain point, I tested positive for Bartonella, which, as the previous presentation mentioned, is one of the more contested of the tick-borne co-infections. But so that was what I had. I had these sort of, you know, probably positive but ambiguous results for Lyme, and a positive result for the controversial co-infection. But the doctors I saw were willing to treat me. And I sort of entered the world of taking combinations of antibiotics, pulsing antibiotics, going off and on them for periods of weeks and months. And this went on for about a year before I made, well, basically before I saw any kind of progress. And at a certain point, I escalated to doing intravenous antibiotics. I didn't get a PICC line in my arm because we had a child who I wanted to be able to carry. So instead, I drove about 45 minutes each way every day to sit in a doctor's office and get, you know, sort of filled with Recefin. And again, doing all of this, you know, my body sort of reacted to it. I had, you know, the pain would intensify, my symptoms would intensify often when I took the antibiotics. But I didn't, you know, there was no sort of predictability, no clear pattern to the symptoms. Nothing seemed to lead to a breakthrough. And you know, our life, meanwhile, had basically, you know, gone from being sort of this fantasy to being a kind of Stephen King novel, where we were living in this house that was, you know, sort of too big and old for us to master. I was in pain all the time and miserable all the time. My wife was isolated with our children. We were both writers. So the joke that we used, and it wasn't really a joke, was that it was just like The Shining, except we were both sitting at the typewriter, banging out all work and no play. And then at a certain point, after the IV antibiotics, I had a kind of breakthrough where I basically figured out that there were certain things that I could take. There was an antibiotic called Tindamax that, if I took it in combination with other antibiotics, could sort of automatically induce these strange reactions in my body, which I think were my version of the famous, also controversial Herxheimer reaction. But basically where I could sort of have this sort of predictable response, where it seemed like I was actually doing something that flushed the bacteria out, exposed the bacteria, and let the other antibiotics kill them. And to the Tindamax, I eventually added many of the, recommended and hotly debated supplements that people take, everything from grapefruit seed extract to oil of oregano to all the various enzymes, serrapeptase, nattokinase, and more. And I developed a protocol that was basically a combination of 3 antibiotics at high doses. One of them rifampin, specifically for Bartonella, the other 2 for Lyme, that I took in tandem with this array of herbs and supplements. And that basic combination enabled me to very, very slowly begin to crawl back to health. So I had 3 or 4 months of total mystery, about a year to a year and a half of intense treatment without any progress. And then since then, I've had about 5 to 5.5 years of, with fits and starts, steady progress to the point where I generally say that I'm about 90 to 95%. And I took antibiotics for 6 of the 7 years. I basically stopped taking antibiotics about a year ago. And I think I've reached a point where there's still some stuff that's latent in my body, but my own immune system is capable of taking care of it. And I usually get flare-ups whenever something happens to weaken me in some way. So we have 4 kids. There are a lot of colds and infections in the house. When I get a cold, I'll get symptoms flaring up from before. And then as the cold gets beaten down, the other symptoms get beaten down as well. So that was basically the sort of core of my story and the core of the response that I ultimately found my way to. But I also did stranger things, as again, many people with Lyme and tick-borne illnesses do. The strange things that were the most effective for me was that I attempted treatment with magnets, where a chiropractor you would lie on the table and the chiropractor would put magnets on your body in symptomatic locations. And I also acquired a Rife machine, which is, an extremely fringe form of treatment that involves sort of running sound waves through your body in the hopes that they will shatter bacteria, much the way an opera singer's voice at the right pitch can shatter a wine glass. And what I usually say when I tell this story is that, the main thing that I want to convince people of is that chronic Lyme disease is real. It is caused, I'm quite sure, in most cases by persistent infection, and can be treated with, versions of the heterodox, but I think pretty scientifically rigorous methods of combinations of antibiotics combined with other things taken over a long period of time. That's the core argument that I want to make. And I think that is a very scientifically grounded argument overall. At the same time, you also want to be honest about the reality of trying to treat something like this, which is that, you inevitably end up trying things that are well beyond the range of scientific certainty or even clear scientific evidence. And I did that, and I think I found things that were helpful for me. And without making any kind of, hard scientific recommendation for them, because I don't think the, capacious evidence is there, it's important to say that, there clearly are things out there that are helpful for people. Other people try other strange things. And a willingness to try the strangest things is sometimes a necessary part of dealing with illnesses that are so poorly understood and so fundamentally destructive. And that's just the last thing I'll say. And I know this is an audience that knows these issues well. But one of the most important things I've tried to convey in writing about this is that when you're outside a chronic illness, you tend to think of it as something that is basically like ordinary life, but slightly worse. And some of that comes from the language that we use to describe symptoms. We'll say, I have fatigue, or I have aches and pains, or I have headaches, or I have, insomnia, these kinds of things. And it's very easy to listen to that testimony and say, well, you have insomnia. Everybody has some insomnia. You have fatigue. Everybody feels tired from time to time. So chronic illness must be, on a scale of 1 to 10, a healthy person is at a 2 or 3 in terms of these things, and the chronically ill person is at a 4 or 5. And for some people, that's probably true. But for me and for many, many others, it's not at all like that. And the language sort of falls short in capturing what it's like. Chronic illness at its worst, it's not a little bit worse than normal. It's an entirely different mode of living in which it feels like your body has been stolen from you in some way that resembles the analogy I kept reaching for when I was really sick, in part because we had little kids watching Disney movies, was fairy tales, that it's like an enchantment. You're under a spell or a curse, and you're waiting for, the solution, the cure, the thing that breaks the spell to come along. And, not completely, but to a large extent, I think I found that thing, or those things, those many things, because I have gotten better. But I just want to end by expressing my immense gratitude to institutions like our host tonight, because every case is different. Every experience is different. There is no one size fits all treatment. And the most important thing in general that we can do is pursue research and share testimony so that we can get closer to having a system in which more doctors, more official medicine is prepared to meet patients where they are and help them escape from the curse that, you can very, very unexpectedly fall under. So I'll stop there. If we have time, I'm happy to take a couple questions.
Hi, Russ. I just want to thank you for your talk, and also the book and the columns you've written on Lyme disease that have been very, very helpful to the Lyme community. We do have one question here. What is the number one recommendation you would have for someone who is going through what you have been through as a tick-borne disease sufferer?
I'll cheat and offer a sort of multi-layer answer, right? The first thing, the most important thing, is to believe that you can get better, and to understand that belief is an act of the will. That you're not going to naturally think that you're going to get better, not least because in many cases you will literally have an infection that is messing with your very mind. Your headspace, not just your body. So the belief is something you have to choose. You have to choose, often in defiance of what your own mind is telling you, to believe that you can get better, because you can. I am quite sure that for almost every chronically ill person, whether or not you can get back to 100%, there is something out there that can make you, over some period of time and experimentation, feel better. And that belief is just tremendously important to hold off the despair that these kind of conditions can bring. But then connected to that is, you have to act, you have to try. And it's a hard thing, but, I had terrible symptoms in certain ways, but I was fortunate in others. Most of my symptoms were pain-based. I had bouts of fatigue, but they would last an hour. I had bouts of brain fog, but they were usually temporary. So as much pain as I was in, I could still be, sort of an agent. I could go talk to people. I could talk to doctors. I could read. I could do the things that were necessary. And sometimes you can't do that. And sometimes you need other people to be your advocate. And that can be tremendously important. But whether it is what you yourself do or what your advocates, the community of advocates around you do, it really is just tremendously important to be an experimenter. If you find a treatment that works pretty well, but then stops working or stops getting you further, you have to try something new. You have to be willing to essentially, find people who can help you, but also always be helping yourself. and it's really, really hard, but I really promise you it's, after 7 years and going from a shell of myself to most of myself again, it really, really is worth it.
Thank you very much. And thank you for speaking tonight. We so appreciate you being here.
Absolutely. It was my pleasure. And, God bless to everyone watching. If you're touched by this disease, it's a profound and tremendous and terrible thing. But there is also hope.
Thank you very much. Bye-bye.
Yeah.
Goodbye. Hello, everybody. I want to just take a short break now and then I'll call up our final speakers for the evening. Be right with you. And our next speakers, Dr. Brian Fallon and Dr. Shannon Delaney, have been working hard on a solution. Dr. Brian Fallon is the director of the Lyme and Tick-borne Disease Research Center at Columbia University. He is recognized internationally for his work on neurologic and neuropsychiatric Lyme disease. He has served on expert panels for the National Institutes of Health in different areas and has received over $15 million in both private and governmental grants to continue his research. Dr. Shannon Delaney is an assistant professor of psychiatry at Columbia University and is the medical director of the Columbia University's Cohen Center for Health and Recovery from Lyme and Tick-borne Diseases, a new Lyme clinic. Dr. Fallon, you are a psychiatrist. How did you get involved in Lyme disease? And thank you so much for doing so.
First of all, thank you so much for inviting me and Dr. Delaney. So thanks to the Southern Tier Lyme. Yeah, I'm a strange psychiatrist, right? Here I am and focusing on Lyme and tick-borne diseases when I should be out there focusing on anxiety and depression. How did I get to this place? Well, years ago, I was studying. First, I was studying anxiety and depression, and especially obsessive compulsive disorder. And obsessive compulsive disorder is characterized by intrusive thoughts. So I then got interested in hypochondria, which is also associated with intrusive thoughts. So here I was focusing on people who were called hypochondriacs, and I started to see patients who I thought weren't hypochondriacs, but that they had something medically that hadn't yet been explained. And I started to learn about Lyme disease. Then I started having family members afflicted with Lyme disease. And then I became convinced that this was a real problem that needed to be studied. I was told by Polly Murray, and my wife, who's a psychiatrist, was also contacted by Polly Murray, the mother in Old Lyme, Connecticut, who first identified Lyme. And basically, she said, you guys should study the psychiatric aspects. So that's how I got involved in it. And listening to Ross Douthat just before, he was talking about the chest pains he was having and the tremendous, which could be misdiagnosed as a panic attack, or maybe they were a Lyme precipitated panic attack. And he was given Xanax and he found it wasn't helpful. And so there's a distinction between the neuropsychiatric and other profile associated with Lyme disease patients compared to regular psychiatric patients. So that's how I got involved.
Thank you. And Dr. Delaney, you are a child and adult psychiatrist. Now you are the medical director of a Lyme clinic also. How did you get involved in Lyme disease? And thank you also for doing so.
Yeah, thank you. Thank you again for inviting us both. It's great to be here. So my story is a little bit of a long story, but I'll try to keep it on the briefer end of things. So I did my training during my residency in Boston in adult psychiatry. And then I came to New York and I did a fellowship in child and adolescent psychiatry. And when you're in residency and fellowship, you often, as a psychiatrist, you'll do consult liaison work in the hospital. So what that means is the medicine doctors sometimes have very complicated medical patients that they're seeing. And they do a multi-million-dollar workup on these patients. They're very complicated. And oftentimes everything came back negative. So at that point, the doctors would kind of throw their hands up in the air and ask for a psychiatry consult. So you can imagine like how excited the patients are to see a psychiatrist after they're in the hospital and they feel like they have a very complicated medical issue that isn't being addressed. Go ahead.
Excuse me for interjecting, but it's so sad. I'm still not receiving Dr. Delaney's talk. Dr. Fallon, could you let me know when?
I'll let you know when Dr. She's doing fine. I'll let you know when she finishes. I'll just raise my finger.
Thank you.
So I was part of the psychiatry team that would come to see these patients that did not want to see psychiatrists. And during my training, I remember the attending psychiatrists would often view the problem, whatever it was, as a very psychoanalytical type problem. So even if the patient, let's say, had left-sided weakness and a lot of medical symptoms, the psychiatrist would often attribute it to some sort of psychological stress that was going on. So I didn't agree with that assessment at all, and frankly didn't understand it, and would get a little bit upset because I thought it was an unexplained medical illness that science basically didn't have answers for and didn't have knowledge base to accurately diagnose it or treat it. So at that point, also, I would have to say that autoimmune encephalitis was just being discovered. This I think is 2009, so this is my intern year, and the condition NMDA receptor antibody encephalitis was just being discovered. And the reason I was so interested in this particular condition is that there's a very specific neurobiology. So there's antibodies that attack NMDA receptors in the brain. And the patient often first presents with psychiatric symptoms, usually psychosis, and then progresses to neurological symptoms. So I was very intrigued that there was a very specific neurobiological condition that caused psychiatric symptoms. So I thought that we could learn more about it. So basically, at that point, I realized I need to do some sort of research to do my part to help advance the field. So I did an NIH research fellowship at Columbia for 3 years. And during that time, Dr. Brian Fallon was my mentor. And I did a psychosis biomarker study where I was interested in looking at infectious and immune markers of psychosis. But during that time, I learned a lot about Lyme disease. And then in 2017, I joined the faculty at Columbia and basically have been doing a combination of medical and, or clinical rather, and research things related to Lyme disease since then.
Thank you. Dr. Fallon, could you please tell us about the Lyme programs at Columbia?
Sure, it's my pleasure. Way back in the early 90s, when I first started focusing on Lyme disease, we were doing it without any really formal support, except for the support of New York State, which was tremendous. I want to give kudos to New York State for all of its support for our work in Lyme disease since the early 90s, as well as to Columbia University for supporting us. Our work started out focusing on research and trying to answer key questions like can we help in the development of better diagnostic tests by collecting bodily fluids and sharing it with colleagues from around the country? Can we help in the objectification of some of these strange brain symptoms patients were having? So one of the first things we did is we started looking at what's going on in the brain, looking at the functioning of the brain using something called SPECT scans. So we were among the first in the country to show that the patients with Lyme disease and cognitive problems or brain fog symptoms had patchy areas of decreased blood flow in the brain. And then subsequently, we did a major study with the National Institute of Health, which showed that once again, that they have these decreased areas of blood flow, but also decreased areas of metabolism. And with that study, we also looked at treatment with intravenous ceftriaxone. So that was what consumed a lot of my time in the 1990s and the early 2000s. Then in 2007, we were given a generous gift from the Global Lyme Alliance and the Lyme Disease Association to set up the Lyme and Tick-borne Disease Research Center at Columbia University. So that was a wonderful thing because that gave us a base of supports to continue our ongoing research. And Dr. Delaney joined us in the I think you said 2017, and that was very productive as well. And then most recently, the Stephen and Alexandra Cohen Foundation gave us a very major gift, $16 million gift to open up a clinical center at Columbia for children and adults that is affordable for patients, and we take many different insurance policies, and also to open a clinical trials network. So you might ask, I'm going to jump to the gun here, we might ask, what is a clinical trials network? And
Yes.
basically it's a network of academic institutions that wants to do research on looking at better treatments for Lyme and tick-borne diseases. So we currently have a very strong collaboration. A member of our network, John Alcott and his group at Johns Hopkins, Dr. Roberta DiBiase at Children's National Hospital in Washington, D.C. And we're looking to welcome some other institutions to our network as well. And the goal is to really conduct small pilot studies that will eventually lead to larger NIH-supported studies to try to demonstrate that there actually are treatments that do work for helping patients with persistent symptoms, most often related to Lyme disease. We can also look at other tick-borne diseases as well, but Lyme disease is the gorilla in the room that's causing most of the problems among the patients, although the other tick-borne infections are also quite serious.
What kinds of treatment are being considered for the study, for the Clinical Trials Network?
I'm sorry, say it again.
What kinds of treatment are being considered for the study?
Well, that's a great question. And we look at any treatments that can help patients feel better. So we, if patients have persistent infection, then it makes sense that repeated antibiotics or different courses of antibiotics or combination of antibiotics might be helpful. If patients have post-infectious problems that are immune mediated, such as ongoing inflammation, then immunomodulatory therapies might be helpful. So something like intravenous gamma globulin might be something we would look at. We're also very interested right now in looking at that great computer in our body, the brain, and saying, okay, well, why are patients experiencing so much pain? Why are they experiencing severe light and sound sensitivity? Why is their brain overreacting to normal stimuli? What was it that led to this problem? Well, undoubtedly, it was the tick-borne infection. But something led to this ongoing problem that makes it very hard for them to go out into normal life and to expose themselves to normal sound or normal sunlight. Why is it that these patients have cognitive problems? So we know from other studies that in the brain there's evidence of inflammation. And so maybe treatment with certain other types of neuroinflammatory modulators may be helpful. So I'll give you an example. One treatment that we're going to be looking at soon is called vagal nerve stimulation. And the vagus nerve is the longest cranial nerve in the body, and it connects the brain to the gut and to the heart and to the spleen and to the liver. We know from animal studies and human studies that if you stimulate the vagus nerve, there's a decrease in inflammation, and people might need fewer pain meds because their pain is less. We know that vagal nerve stimulation can help with depression. It can also help reduce seizures in people who have epilepsy. It can also reduce headaches in people who have migraines or cluster headaches. So there's a lot of opportunities to think, or at least there's a lot of reason to hypothesize that vagal nerve stimulation may be of benefit to some of our patients who have persistent symptoms. So that's just one example of modulating the brain, the cranial nerve, or modulating other brain networks to help alleviate some of the ongoing symptoms that people experience. And some of the nice things about these treatments is that they can be done at home without having to come to a center.
That's all very exciting. How can we learn more about the treatment studies and about what is planned for the near future?
Well, certainly you can check our website for the Clinical Trials Network, which is limectn.org. We actually have a call for proposals right now. So if you're listening and you're from an academic medical center, or if you have a good research idea that you want us to test out, please propose that as a research idea. We're accepting proposals until June 15th, and then we'll review the proposals to see which ones we think should be pursued. Or you could go to our website, which is columbia-lyme.org, and there's a lot of information there, both about our clinical program as well as about other research we've done in the past.
If an academic center here in the Binghamton area is interested in participating in the Clinical Trials Network, should they reach out to you?
Oh, I hope they do. I would love to hear from them.
That would be great.
So please give them my email.
And I will. And when will you post your next request for treatment study proposals?
Well, it's open right now, so
okay.
It's
okay.
Yeah. So they just have to go to our limectn.org website.
Okay. Thank you very much. Dr. Delaney, have some questions for you too.
Sure.
And I'm sorry I can't hear them, so your answer. So if Dr. Fallon could continue to help me, that would be great. Dr. Delaney, can you tell us a little bit about the new Lyme clinic? We're all very interested in hearing about it.
Sure. Just 1 second. Something just popped up on my screen. Okay. So yeah, like Dr. Fallon mentioned, we have a new clinical treatment center. It's called the Cohen Center for Health and Recovery from Lyme disease and other tick-borne illnesses. We are up and running, seeing patients virtually since August, but we are undergoing construction of our space. So we have mainly telemedicine appointments at this point. So we are limited in terms of the patients geographically that we can see because of that. I would say that we also have somewhat of a waiting list at this point and a limited capacity to see new patients, but we are in the midst of hiring additional medical practitioners, so we will have increased capacity in the future. But like Dr. Fallon mentioned, no Lyme disease patient is the same, and they really do present each with a different, unique story. And I think that's, as clinicians, that's what we learned pretty early on with Lyme disease, that there is no typical patient, which makes it harder to diagnose and harder to treat sometimes. But we do a combination of various things according to what we think is clinically appropriate. So sometimes additional antibiotic treatment, sometimes herbs and supplements, sometimes recommending immunomodulatory treatment like IVIG.
Thank you very much. There are a couple questions I wanted to be sure to ask you, and unfortunately I couldn't hear your answer to the other. So, but I do want to get it in just because it's important to me. Have you mentioned how long the waiting list is for an appointment at the clinic?
Right now, well, it's a little bit difficult of a question to answer. We are booking in June right now for our primary physicians, and somewhat of a longer waiting / interested list from there.
And the other question I wanted to be sure to ask, well, it's my understanding that the clinic accepts several forms of insurance. I'm not sure whether or not you mentioned that, and is that true?
I think Dr. Fallon mentioned that actually, but yes, that is definitely one of the missions of the Cohen Center, is we wanted to make sure that people had affordable treatment at the center. So we accept the majority of insurances. I think there's maybe like 1 or 2 that we do not accept. I think Cigna is one of the ones we don't, but otherwise we accept most major commercial insurances.
Thank you. I just received a message from our technical person. I'm still not hearing you, but our technical person pointed out to me that a mission of the clinic is affordable medicine, and we are so grateful for that. Believe me, our Lyme community is so in need of that. Dr. Delaney, you have treated many children and adolescents who have pediatric acute onset neuropsychiatric syndrome, or PANS, that can be triggered by Lyme disease. Could you explain to us what this is about and how children who have this condition are treated?
Yeah, that's a good question, because it's definitely a lot of the patients that I see have a history of Lyme disease. Some of them hadn't been diagnosed by the time that they come to our clinic. But PANS is an acronym, like you said. What it stands for is Pediatric Acute Onset Neuropsychiatric Syndrome. And basically it describes new onset psychiatric symptoms that are thought to have come from an infectious trigger. Usually the infectious trigger most commonly is strep infection, mycoplasma, or Lyme disease. I see a lot of Lyme disease and mycoplasma, and some less so from strep infection. But basically these new onset neuropsychiatric symptoms in kids can be very severe and abrupt and very debilitating. So oftentimes it's new onset OCD behaviors. It can be severe restricted eating, so anorexia that develops kind of out of the blue. A lot of these kids suddenly have involuntary movements in their different parts of their body, or tics. They can develop separation anxiety, so suddenly a kid that was very social now is refusing to go to school and clinging to his mom even at an older age. We see a lot of emotional lability, with sometimes severe depression, also suicidal ideation, and sometimes suicide attempts as well, which are obviously very scary. A lot of these kids can have urinary frequency, and the more severe cases can have urinary incontinence and also bowel incontinence. So it can be a very severe, scary situation, and it can be very chaotic for the families who are trying to understand what's happening to their kid. I frequently hear from families who say, they're a complete wreck, and they say that their kid has completely changed their personality. The poor kids, when you talk to them and you ask them about their changes, they'll sometimes describe it as having a monster in them. And the parents actually will also describe that when they undergo these episodes, which can last anywhere from 15 seconds to sometimes like 30 minutes or an entire hour, they feel very disconnected from their kid, and they have almost psychotic level symptoms. So the kids that I see, sometimes when they come to me, they don't have a diagnosis of Lyme disease, but then we do a comprehensive workup and we uncover that this kid actually does have a history of Lyme disease based on the laboratory testing and based on the way that the clinical presentation presented itself. Other times they have a known history of Lyme disease and they're presenting with these neuropsychiatric type symptoms.
I think I'm going to add here. I think it's worth mentioning, because that's very scary to hear what's going on with these children, and it's a very dramatic picture that no, all I wanted to say was that people can get better, and the children can get a lot better with the excellent care that you provide, Dr. Delaney, and there are a variety of different modalities by which the children can get better. So even though they're profoundly ill, they can get a lot better. It takes time, though, right?
Oh, that's good to hear.
Yeah, I would add that with appropriate treatment, which is sometimes a combination of antibiotics, psychiatric medications, the right ones, and oftentimes immunomodulatory treatments like IVIG, the kids can transform their lives, and they can get back to their normal selves, their original self. As one kid said that his original self was gone. I do see them getting better. There's just often a lot of like ups and downs in the process, unfortunately.
Dr. Delaney, do you want to say anything about Borrelia miyamotoi?
Sure. You know how much I love Borrelia miyamotoi. So I started on faculty in 2017 at Columbia. And at that point, I really was learning about Borrelia miyamotoi for the first time. And I realized at that point, we didn't have a clinical treatment center, but we had just a consultation center. But we were regularly testing for Borrelia miyamotoi, which is a bacteria that is similar to Borrelia burgdorferi, except it's part of the relapsing fever Borrelia family. And so we were testing basically everybody that came through the door for antibodies towards Borrelia miyamotoi, and I was quickly seeing that we were developing like 25% or more of the patients were showing that they were serologically positive for this antibody, which I felt was amazing because this was something that most doctors had never heard of. Most patients had never heard about this disease. And I had never heard of it before joining this Lyme group either. So we started systematically testing for this in patients who had not been tested for it before. And after about a year and a half of data, we published our data in 2020. And we did show that 26% of everyone in our consultation clinic who presented with symptoms suggestive of a tick-borne illness, all of the patients who came to us, they didn't have to have a defined tick-borne illness prior to seeing us. 26% of everyone were antibody positive for Borrelia miyamotoi, and 98% of the patients that had seen us in the clinic had never ever been tested for this before. So it was pretty amazing findings, I thought. And the other reason why it's very important to know about is basically it's a bacterial infection that presents very similarly to Lyme disease, virtually indistinguishable in terms of we compared our Lyme disease only group compared to those who had evidence of being exposed to Borrelia miyamotoi, and there was like no difference really from a clinical standpoint. The other important thing to know is that Borrelia miyamotoi usually does not present with a rash at all. So unlike the EM rash that you get from Lyme disease, people typically don't get a rash at all. So ever since then, I've been very passionate about learning more about Borrelia miyamotoi, making sure that everyone is tested about it, and that people are properly educated in that arena as well.
Yeah, one other point that Dr. Delaney described it really well, Borrelia miyamotoi, Peter. So just one more point on that, which is that there is a test that is available. You can detect Borrelia miyamotoi antibodies and even by PCR. So that is available also at one of the national laboratories. I think it's Quest has it.
Yeah.
Thank you. I just have a couple questions from the audience. One is, what lab does your clinic use for testing for Lyme?
So we usually use a combination of a few different labs. So we will sometimes use Quest Diagnostics, or we usually do use Quest Diagnostics for standard labs, and also for Borrelia miyamotoi, because they actually acquired Immugen, which was a specialty clinic that actually had been doing testing for Borrelia miyamotoi. So we typically do a combination of Quest Diagnostics, Stony Brook, and also Medical Diagnostics Lab in New Jersey, which is a tick-borne specialty lab.
Yeah, I think it's worth mentioning. There are many possible labs that we could use, but those are the ones that we've been using for many years and we're most familiar with.
One other question, I think this will be the final one. Does your clinic, and this is from the audience, does your clinic provide assessment and testing for people of all ages?
The answer is yes.
Thank you. And I'd like to thank you, Dr. Fallon and Dr. Delaney, so much for being here today and letting us know about what is happening at Columbia University and the clinic. It is, we put your segment at the end so that we could end on a happier note. And believe me, having a clinic like yours is just such a great thing for the Lyme community. And so we thank you. I'd also like.
We thank you, and we also want to special give thanks to the Cohen Foundation for their generosity in supporting Lyme disease research throughout the country, as well as the clinical and research program at Columbia.
I'd also like to thank our audience for bearing with us on the technical issues, and enjoyed very much talking to you, Dr. Fallon, and you, Dr. Delaney. Thank you for being here. And at this, I would like to go ahead and end the program. So take care now.
Okay, thank you.
Thanks for having us.
Goodbye.
Bye.